Chest tubes are used to remove air or fluid from the pleural space. They are inserted by a provider and are most often placed in the OR by the pediatric surgical team. In pediatrics, they are often used for a pneumothorax, a complicated pneumonia, or a lung injury. A chest tube is just one piece of the treatment plan, and they are often used in combination with other treatments, such as antibiotics and oxygen. A Pleur-evac dry suction is the most common drainage system used on BBI. You adjust the suction control based on the order. There's an orange bellow indicator, seeing if the suction is on and working. At the bottom, you can see an air leak meter that requires water to be to the fill line for it to work. There's also an area to assess and measure output. The Pleur-evac wet suction is also used. The major difference is that this system uses water to set the suction level, and the water must be filled to the line that matches the desired suction control order. This also has an area to watch for an air leak and one to assess and measure output. To set up the Pleur-evac system, water from the squeeze bottle on the device goes into the top of the suction port to fill appropriately. The Shore drainage system is the backup system that may occasionally be seen on BBI. This system has a similar setup, which includes a suction control setting, an air leak monitor, and an output canister, but the suction indicator is a red circle rather than the orange bellows. To fill the Shore system with water during setup, use the syringe on the back of the device and connect it to the port on the back of the system. A Topaz device is the preferred drainage system by pediatric surgery, but they are not often available. Any drainage system is interchangeable as per supply chain availability. The Topaz device is an electronic system that records totals on the screen. This may not always be accurate, though, so look at the canister to measure and assess output. This system reads more accurately when upright and even, but can be tipped and moved without needing to be changed. This system alerts for air leaks on the screen, and the settings can also be changed to reflect your orders. To water seal this device, click both arrows on the bottom simultaneously, and then click the Physio button and the OK button. Water seal on the Topaz is -8 centimeters of water. The nursing team manages and assesses the chest tube in use. Chest tubes only work if they are maintained in the correct position, but one important note is that chest tubes cause discomfort. It is necessary to provide adequate pain control and distraction to these patients. Utilizing a non-violent restraint may be necessary, as well as education and inclusion of the parents and members of the wider team, such as Child Life. Assessing and measuring output is an important nursing task. Monitor for the color and characteristics of the drainage, as well as the volume. Mark on the device with a time and date to ensure the volumes and assessment information is updated in the chart. The insertion site needs to be assessed a minimum of every 4 hours. Assess for drainage and placement, and ensure the dressing is intact and occlusive. If the suction indicator is not on and the patient is ordered for suction, first check that the wall suction is on and working. Suction on the wall may need to be turned up. This does not affect the chest tube suction as long as the suction control is set to the right number. Ensure that the tubing is fully connected from suction to canister and plugged into the top valve of the drainage system, and make sure that the suction control matches the order. Some bubbling is expected after the initial placement of the tube, but if you see bubbling in the air leak chamber when it has previously stopped, look at your patient and assess. Check that the chest tube is in place, the dressing is intact and inclusive. If the dressing is peeling up at all, add an occlusive dressing as necessary to reinforce. Then check the tubing and connections from the patient to the drainage system. If all is intact and there is still bubbling in the chamber, alert the provider to a potential air leak. If the canister falls over, first assess your patient and the chest tube site. If they are stable and secure, set the canister upright and check all the connections on the drainage system. If there is spillage or the canister is broken in any way, replace the drainage system. If the chest tube is ever disconnected or broken and cannot be reconnected, use the emergency clamp and page the provider. If the drainage system needs to be replaced, first set up the new drainage device. You can transition to any brand available. For example, if your patient has a Pleur-evac, it is okay to swap it over to a Shore. First, add water to the fill line. Clamp the patient's chest tube using the Kelly clamp. Unclip from the old canister and clip it into the new canister, and then unclip the patient and check for leaks and suction. Patients should be clamped for as little time as possible. If your patient is ordered to be put to water seal, turn off the suction and unplug the suction from the top valve. You do not need to clamp or do anything to the chest tube or patient. Continue the same monitoring. On the Topaz, use the screen to change the settings. If there is decreased or no drainage, the provider may order tissue plasminogen activator, or TPA. If this happens, the provider comes to the bedside and administers the medication. The nurse then rotates the patient frequently, about every 15-minute position changes, such as right side up, left side up, sitting up, and laying down. After 1 hour, the nurse unclamps the tube and ensures the patient is back on the ordered chest tube settings. If a patient has a chest tube, they are considered high risk and should be assessed accordingly. There's a low threshold for calling a pediatric rapid response. There is always a risk for chest tube dislodgement, which is a medical emergency. In each room, there should be a chest tube emergency kit with one for each tube. The kits can be found assembled in the back corner drawer of the treatment room. The kit includes a plastic clamp, occlusive gauze, dry gauze, and Tegaderm. If the chest tube is fully dislodged, use the kit and cover the hole with occlusive gauze, dry gauze, and Tegaderm. If the chest tube is only partially dislodged, stop the suction, clamp the tube, and cover the site with the same emergency supplies. In either case, assess your patient and call a code if necessary. Always call for help and do not leave the patient alone. Place them on continuous pulse ox monitoring. Page the provider and prepare for a stat x-ray and possible replacement of the tube. Do not cut the sutures. Then complete an RL and significant event note. Work with the wider team to ensure that these patients are well taken care of.